a lot of people came back to us saying, well, how do you involve consumers in training? I don't understand why. I don't understand why we need to do that. And we did actually get some people who were interpreting it in some really interesting ways. And what we tried to keep saying back to people is that you don't need to, we're not saying that you have to train a consumer to deliver training to your clinicians. You don't have to get someone who can come up and do a 2-hour session on, the standards and how you partner with consumers and that kind of thing. There are lots of different ways that you can do that. And a lot of it, and some of the most the types of actions with the most impact are just when you use consumer stories. So if you can do that in a range of different ways. You can have people do like a video or an audio, or you can record or you can ask them to tell you their story, and then you can have someone go to that meeting and then report back if the consumer doesn't feel confident enough to do that. You can integrate different kind of snippets into different training sessions and PowerPoint sessions. There are like a range of different ways that you can, and it is quite powerful, and it does have quite a bit of a reality check for some people when that actually works well. I'm very loud. Thanks, Michael.
I trained her well.
So there's quite a lot of effort and time and investment required both on the health service and on the consumer.
Can you hear me? Yeah. One of the things that I was disappointed you didn't mention, Naomi, is the importance of health consumer organisations, whether they be national, state, peak bodies, or disease-specific or regional or community-focused organisations. It seems to me that they are actually critical to providing a wider perspective and support and endorsement and a bit of oomph in their roles. Many people who have experience as consumer representatives or involvements in some of these kinds of accreditations are lone voices. And we heard the Minister this morning talk about this new policy and a consumer voice. I mean, the consumer voice is really varied, and that's the thing that consumer organisations bring to bear. They can enable one or two people in these roles to actually articulate the widespread and varied experiences that consumers and patients and their families and their carers and their friends and family all have. So I can't emphasise enough just how important the consumer health organisations are, and they need to be resourced and supported and treated as equal partners.
Yeah, and I totally agree with you, and I apologise for not mentioning that earlier on in the speech, but consumer organisations are critical for this because they provide a lot of the infrastructure, the support, the experience. They support a lot of the consumers who are involved in these processes, and without them it would be beyond an uphill battle for a lot of these health services to actually achieve this.
Hello. Hello. I came in a bit late on the discussion, so I apologise if this might not be quite within the range of what you're discussing, but how do you work out obviously the standard has to be expressed in a fairly concise form to cover a whole range of different aspects. And as a consumer or patient, that may actually look a whole lot different. There may be lots of different ways of meeting that standard or different processes involved in that standard. How do you where do you stand, I guess, or maybe just a comment in my experience where you have an expectation that looks like it fits under the standard, yet the health service comes back to you and says, oh, I'm sorry, that's not actually what the standard means. And how do you then communicate what actually falls within those standards? I mean, it can't be a finite list of, and to use an example, consumer communication or carer involvement. Like, there could be a myriad of ways that happens. And so I don't see that as a finite list, yet a health service, if you have a particular complaint, and I have personal experience, has said, well, that's not actually what it is, and our interpretation of that is this situation. So how do you cater for the fact that the actual, perhaps even implementation guidelines or the actual many different things that could be encompassed by that concise standard, how do you then, as a consumer or a patient, make sure that or work with the health service or get the health service to understand that that's incorporated under that actual standard? Does that make sense?
No, I know what you mean. It is quite difficult because the way that the actions are written within the standard are deliberately quite broad, and the reason for that is because it needs to be applied across an incredible variety of different types of services, and so we can't be too specific in case it just makes it unachievable for, maybe a 3-bed day surgery in a country town somewhere kind of thing. So we need to keep it fairly open, and we don't actually, within the action, be too specific about what that actually means. But at the same time, what we do is, you're probably familiar with we develop a series of safety and quality improvement guides for each of the standards, and that outlines like a range of different strategies that hospitals or day surgeries or community health services could use in order to meet those actions. It's by no means an exhaustive list, and so there are, millions of other strategies that a health service could use to do that. And I guess what we try and do is we try and be as clear as we can be about the intent of the standard rather than how you actually achieve it. And the health service is ultimately responsible for identifying kind of which activities they do in order to meet the standard, and the accrediting agency will assess against that kind of thing. And because it is kind of so general, it is a little bit of a kind of between the gaps thing if you have a particular idea about how that could be achieved, which may not mesh with what the health service says. I would suggest, you probably already talked to the consumer and community engagement person within the hospital about your ideas, or if you, is there any opportunity to raise it if you've got consumers on any kind of committees or governance structures within that health service? Or it may be that you could talk to your state-based consumer organisation, because it may be that there's a pattern of things going on that they've seen with other consumers. So I guess I would talk to some different people either within that health service or around the kind of consumer and community engagement kind of community here in Queensland, and see if there's something there that you may be able to use as a lever.
How transparent are they? Sorry.
In terms of, do we get to see what they?
Yeah, I mean, how transparent are they? Do the public get to observe them?
No, so we get aggregated data about basically METs or not METs, or met with merits. So we basically just get the total data. So we don't actually get which of the actions for a particular hospital has not been met, or what they've done to actually achieve that. So as I understand it, the accrediting agencies have that data. Some of it, if there is a situation where a hospital hasn't met a particular criterion and it's of concern, then I understand the regulators will be able to follow up on that. But we just get total figures. So we will get annually figures to say that, if only 1% of people are meeting standard 2.1 or something, and it looks like it's really unachievable, then we will get that data and be able to use that to inform where we go to next, but we don't get the individual level.
Yeah. Naomi, I think that's just what I'm saying. It just only comment. It's not, maybe it has nothing to do with what you say, or it has, but I'll say it. If we are going toward personal-centered care, then we need the involvement of a person who present the potential consumers. Somebody like community health workers or community consultant who needs to be involved in the committees or in the advisory committees in hospitals, kind of equip the service providers with the expected service from the community, or equip them with the all needs before the consumer come or access the service. Not only the consumer who's been through the service and suffered. No, we need to be above that. Thank you.
Sorry. I agree, and that's actually, we've been a bit clearer about that in the next version as well.
Sorry to hog this. I just wanted to make an observation about transparency with this, and that I think that's one of the deficiencies with the process about accreditation. When some of the other professional organisations, for example, the medical colleges, are having their continuing professional education and other programs assessed and accredited, there is a publicly accessible process whereby organisations or individuals who are dissatisfied can put in submissions pointing out the negatives as well as the positives, and I think that would be something worth thinking about in the next versions of these.
Yeah, no, I agree. I think that's a useful step to go.
So just as one of the challenges, it's a consistent theme that comes up in the discussion, and it has in both discussions that we've had this morning, is capturing the value of the partnership in the standard. So the hospital, the systems need to start reporting on both the cost, the value, and the opportunities that presents to the hospital. And we talked about examples of avoiding rework. So early in my piece, we would often get documents, I'll get the consumers to review this, and you'd go, well, this is woeful and it doesn't meet health literacy standards, and it's, here's all the things, and they go back with red ink all over it, and they go, but we spent 12 months building that, and now we're back at square one. Yeah, should have asked us 12 months ago. Thanks for coming. So how do you account for some of those improvement costs as well? So I think capturing value in that is important.
Lovely. Well, I might just quickly go on to...
I'm sorry.
Sorry, do you need to finish?
No, you got a few words.
Cool. Okay, so I might just quickly cover off where we're going to with the next version of the standards, because I'm sure some people are going to be interested in that. So we have done a bit of a reviewing of the current version of the standards. We've talked to a lot of people, we've done some surveys, we've got some evaluation data and some accreditation data. There were a few challenges raised, and some of the key things were things like engaging senior leadership, which was not surprising, resourcing, and also just not people having difficulty understanding what they could do to go about implementing these kind of things. But there are also a lot of people who saw the positives in it as well. And there was quite a few organisations who have been started along this track already and just saw the introduction of this standard as a kind of validation and a tool that they could use in order to kind of move their case forward. I'm just going to skip over some of them. So people saw it as kind of supporting their existing approach and giving the work that they were currently doing a sense of urgency in order to move that forward. Okay, so the next version of Standard 2, we're currently in the process of doing it. So there's looking at the overall standards. So at the moment there's 10 standards. The new version that we're proposing is actually going to be 8 standards. What the change is going to be is that there are pressure injuries and falls will actually be included in this new comprehensive care standard, and patient identification and procedure matching will go into communicating for safety. So all of the bits that were there before are still there in some form, but they're just rearranged. 2 of them are rearranged into this new standard. This new standard is actually going to be of interest to quite a number of people, because basically what it is it's about ensuring that care is collaborative, integrated and goal-directed. So there is significant overlap with this new standard and the Partnering with Consumers standard. So it's making sure that organisations have systems in place to support and implement goal-directed care. And it also, so it's structured in a way that that there's integrated screening and assessment of risk of harm. And then once that assessment is done, then healthcare providers need to work in partnerships with consumers to identify their goals and their preferences for care, to work to share decisions, to plan it out, to document the care and to review and revise as you go through. So there's quite a lot of kind of synchronicity there. The Partnering with Consumers standard is actually changing a little as well. So we will still have the governance parts in there, but there was quite a bit of duplication in the existing version of the standards. And so what we've done is we've grouped the overlapping items together. So we will have a governance systems criteria, but the new parts are largely criteria 2 and 3. So we're actually expanding out to include some actions around partnering with consumers in their own care now, rather than just in governance, and also some actions around health literacy, which has come out of the work that we've done over the last couple of years in that area. So what this will cover is things like we working with consumers to, again, share decisions, to identify who they want involved in their care and to document that so that that's followed through, making sure that there is the informed consent processes that are basically meaningful and useful, and that when people are provided with information, that they're also supported to the extent that they need to ensure that they understand what's being discussed, and that using different techniques to actually confirm understanding of information. So it's quite a bit bigger than it was previously, and it covers both of those sides of partnering with consumers. So this in itself is actually going to cause quite a bit of disruption and change in the sector. So combining this new Partnering with Consumers standard with the Comprehensive Care standard is going to require thinking in a different way about how you go about doing that, and will also require a bit of kind of constructive thinking about where those overlaps are, so that when health services look at the standards and think of what they need to do to meet the requirements, that they make sure that where there are synchronicities, that they use the same strategy to meet a number of actions in there, and that there is kind of uniformity and it's a system-wide approach. So that's what I've just said. I will skip that because we're almost at lunch. So with this new version of the standards, the stage that we're up to is we are doing, once again, the regulatory impacts assessment. So what we're doing is we're having a look at the actions that we've proposed, and we are identifying what type of impact that may have on the sector, what the burden might be. And we're proposing, there are 3 options that we need to propose in order to determine whether or not we use a staged approach or change completely into these standards. That would be a public consultation process, so this will come out in July, so pretty soon. So the options for implementation will be there for the assessment, and also the current version of what those actions and standards will look like will come out fairly soon. And so what we then need to do is we need to get the feedback about the impact on the system, and then work through processes to identify what the implementation plan is going to look like. But at this stage, we've had quite a bit of support for the 8 standards and where we're going, and even the comprehensive care standard, which does look quite different from the previous standards. So what the trajectory that we're on at the moment is, through this process, we'll do some further consultation, and we have started developing the new set of resources that would need to go alongside these documents. So again, we'd have the safety and quality improvement guides, which will have all the different types of actions that people could do. We're focusing this time as well on some case studies to make sure that people can kind of see in action what this might mean, and to highlight some of the really good work that people are doing around the country. Because one of the things that we have been thinking about for quite some time is that there are some extremely high-performing organisations in terms of partnering with consumers, and we'd really like the opportunity to actually kind of showcase what they're doing, so that all of the other organisations who may not be doing so well, who may be struggling to come up with some ideas about how to do this, can just see the kind of plethora of options that are available. So that's something else. And we're going to be doing some training and quite a bit of work with the surveyors and the accrediting agencies, just to ensure that when the new version does start, which is likely to be around 2018, that all of the agencies and surveyors have a consistent understanding of the intent of these standards and the actions and how they can be addressed. So that's where it is now. We're doing a whole lot of other work within our portfolio that supports this. So some of the things that you may be interested in, we're developing some resources about shared decision making and risk communication, because there's quite a bit of research out there that communication about risk and benefits from 4 different procedures is not optimal at the moment, and there is a lot of variability in how risks are communicated to consumers. And so we're working on a training module for healthcare professionals, just to give them some kind of ideas around how it might be communicated in different ways. And I think it was Tracy was talking this morning about the work that's been done in Canada around shared decision making and decision aids. We're also developing a number of decision aids for some of the key clinical areas that have been identified as having some variation across Australia. So things like antibiotic use and knee pain and those kind of things. And also the last one at the bottom, which is one sentence but is actually quite a big piece of work going forward into the future, is the Commission's also starting to look at how to create a person-centred healthcare system. So there are levers within which we have some kind of control over at the moment, which is through the standards and those kind of things. But there are also a whole lot of barriers to creating a healthcare system that is person-centred, which may be around funding and structures and the way that kind of operational governance exists at the moment. So we're looking at, if you are looking at the system, the healthcare system as a whole, and it is as a complex adaptive system, what are the types of levers that we might be able to, or we or others might be able to influence in order to shift the paradigm a little so that it can be more patient-centred. And that's it for me. So if you have any questions, or if you want to know more about the standards, feel free to ask me. It is in an interesting place at the moment, and we are at a point when we are developing different types of resources and materials to help support organisations going forward in this change. And I think that much as the first version of the standards disrupted thinking and created some discussion and some some creative thinking around how you can partner with consumers, I think that we're moving towards some new opportunities and different ways that we can actually influence partnerships as well. And that's it. Thanks. Buzzer?
Thank you. Yeah, look, Naomi, thank you. That was one of the best summaries of the standards that I've heard, and I've heard about 3 or 4 of them. So thank you for that. It's very clear and concise. Can I ask you just to put your hands together and show appreciation for Naomi?